Good afternoon, friends. It's indeed a pleasure to be here, and I must thank the organizers and especially Dr. Mohsin for inviting me to this wonderful conference. Now, heart failure has become a very big public health problem globally. As patients are surviving longer, as their mortality is prevented, eventually they go on to develop heart failure. And as we know, heart failure it's a very progressive entity, so patients gradually decline, but this gradual decline is interrupted by frequent hospitalizations sometimes, and these are the times when the patients have go into acute decompensated heart failure and they need a hospitalization and aggressive treatment. So the important point here is that most of the patients they start decompensating quite early, and we are not able to recognize them, and patients themselves are not able to recognize the decompensation till one day they land up in emergency with an acute heart failure. And so the treatment is then reactive mostly. The patient has an event and then he stays in hospital for a few days and we manage him. But if we are more proactive, that is, if we have ways to identify this development of decompensation early enough and the patient is having mild symptoms, probably we can be more proactive and we can do some intervention early enough, and the hospitalization may be prevented. So that is the purpose that I'm going to start with my topic of remote monitoring as to how to stay in touch with the patient and how can we monitor the patient from a remote location, because many of our patients they come from faraway places where they don't have enough good facilities for monitoring, and a lot of things can be done to monitor these patients for development of early signs of heart failure. Now, telemedicine and remote monitoring have come a long way. All the elements existed before the COVID pandemic also, but COVID has given an impetus to this transition into remote care. And a lot of physicians are now using remote monitoring for their patients, especially those patients who have arrhythmia or heart failure. So, and it's very relevant to countries like India and Bangladesh, where we don't have too many specialists everywhere in smaller places, and population is quite dense, and the technology costs have become very affordable. Everybody carries a video phone and has enough data to do a video conferencing. So that has really become a very big tool for patients to connect with their doctor from distance. Now, what can be monitored from remote? Of course, there are some, even if we forget the high end technology, some simple things can be monitored. We tell our patients of heart failure to record daily morning weight. That is, after toilet and before eating or drinking anything, if they record their weight daily, that should be fairly constant. And if there is a sudden change in the weight, that indicates that patient is accumulating fluid, especially heart rate. Heart rate is another parameter, blood pressure is another parameter. So these three parameters can be monitored very carefully every day, and patient can report if there is a change. Then we have some other monitoring techniques. For example, thoracic impedance. The patients has have some CRT device or some pacemaker implanted. They can monitor thoracic impedance, or we have pulmonary artery pressure, which can be recorded through a device, or LA pressure can be recorded, but these are not generally available to most people. And with the help of a smartphone, the data from patient can be transmitted through any CRT device or CRTD device, or even pacemakers can transmit data today. And that can be assessed by the doctor, and we can have a video consultation. Thoracic impedance has become a important one of the tools that can be used to monitor development of heart failure or fluid overload. So basic premise is that if the lungs are wet, that is the patient is developing pulmonary congestion, the lungs become wet and they become good conductors of electricity. So the impedance falls. And if the patient has a baseline trend and we find that there is a sudden fall in impedance, thoracic impedance, that indicates that patient is going into a heart failure. And patient can get an alert, audible alert, and can contact the doctor. And then we can increase diuretic, or we can talk to the patient about reducing fluid intake, and that can help. So this is classically the situation where the patient has development of fluid intake, fluid overload, and there is a fall in thoracic impedance. This data also shows that this is the baseline impedance on the left side, and we have the fall in impedance on the day of admission when the patients are hospitalized with acute heart failure. And as the patients are treated and the pulmonary capillary wedge pressure falls, the impedance rises, and here we can see the fluid balance is also shifting. So this has become one important tool, and it has also been shown to correlate with the change in mortality risk. So that is something that can be done. PA pressure monitoring is not very popular. Even if these are the latest recommendations which show that say class 2B indication. As such, it's very expensive and not available to most people in our countries. But what is interesting is that a multi-parameter device-based monitoring is coming up, where the device will monitor intrathoracic impedance and multiple parameters. One of them is impedance, one is activity. It can monitor night heart rate variability, arrhythmia burden, both PVC burden and atrial fibrillation burden can be monitored, and that can be used to indicate whether patient is going into heart failure or not. And arrhythmia burden is very important through the device in heart failure patients, because AF is very common in heart failure. And if the patient has atrial fibrillation, they also require anticoagulation. Besides the fact that it can aggravate heart failure, these patients also require anticoagulation for prevention of stroke. So devices can report about the frequency, about the overall burden of arrhythmia, and that can be very, very helpful in managing these patients. So remote monitoring has been shown to reduce the number of hospitalizations. It has also been reduced to have better survival, and so it reduces clinicians' time. It also reduces emergency department visits. So it is something very, very helpful. Of course, there are challenges that clinicians and patients have to accept it. There has to be a regulatory framework. In India, we have a document from the government which promotes telemedicine and gives the doctors some validation or some authority to conduct a remote visit or a virtual visit. But because that is very important, from the your medical council has to approve it. A teleconsultation, if you advise some treatment to the patient and patient has a bad outcome, then sometimes the doctors are scrutinized as to why they did a teleconsultation. As far as guidelines are concerned, as early as 2015, remote monitoring had been labeled as a class 1 indication, and even the latest guidelines for at least for CRT and CRTD indicate that remote monitoring can be very helpful for these devices, and these are the devices that we often implant in heart failure patients. What we are looking for is a more robust validation of multi-parameter indices and incorporation of more sensors in heart failure devices, and a greater use of artificial intelligence and neural networks to identify patterns which will identify patients who are going to develop heart failure. Now, for next 4 or 5 minutes, I'll talk about some device algorithm that's part of my talk in CRT patients to manage heart failure more effectively. Now we know that CRT can have very different outcomes in different patients. So we can have 15-20% patients who are super responders with CRT. There are a good number of patients who respond about 60-70%. But there are some patients who have a flat line. They become non-progressors. That is, they don't deteriorate, but they are not improving also. And then there are non-responders who continue to go downhill. And of course, we have negative responders, very few who respond negatively. But by and large, about 60 to 80% patients, they respond very well to CRT. Percentage of biventricular pacing has been a very, very important parameter that is reported by the device, and we can optimize the device to achieve the maximum parameters, maximum CRT delivery. But the most important parameter, which is called suboptimal AV timing and VV timing, you see CRT has three leads. So it needs to synchronize very well between the atria and the ventricle and within the different segments of the ventricle to give a better outcome. So this AV and VV programming has conventionally been done through echo guided parameters, but most of the studies have shown that it is not very helpful. So very uncertain results, because echo guided parameters are not reproducible. Patient goes from clinic to clinic and will find different parameters. So that is something. So now automated algorithms have been developed, which I will talk for next 2 4 minutes, One of them is Sync AV CRT from Abbott, which is a very good algorithm. It basically integrates everything. It integrates the LV pacing, the RV pacing, and the native QRS complex to form a fusion. And by assessing the native timings of the AV interval and VV interval, it can calculate and it can come up with the best possible solution to integrate all the paced and sensed impulses into a fused kind of spread of depolarization in the ventricle. And that has been shown to produce the narrowest QRS and give best outcomes to the patient. It has been shown in the clinical studies to benefit the patient as well. And in the LV only mode, it can pace only in the LV also. Medtronic have a algorithm called adaptive CRT that also works in a similar manner, that it avoids unnecessary RV pacing. It utilizes the native RV impulse because most of these patients have left bundle branch block. Their right bundle is conducting normally, so they utilize the native RV impulse and fuse it with the paced LV impulse. And it works within certain parameters that the patient has to have a normal AV delay of up to less than 200 milliseconds, and of course the heart rate should be less than 100 beats per minute. And if any of these parameters are not met, then it goes into adaptive by IV. So when it comes to programming, we can choose between adaptive IV and LV. If the patient is conducting one-to-one, we can go into adaptive IV if the patient has AV block, and non-adaptive if the patient has permanent atrial fibrillation. Lastly, we have another algorithm, Smart CRT from Boston Scientific, which utilizes again automatic. It's a automated algorithm. It looks at the native AV delay and VV delay, and then it comes with the individual personalized sensed and paced AV delays to maximize the patient's hemodynamic response through CRT and help the patient. So these are three algorithms. There are of course numerous algorithms, but the time was very short, so I have not been able to cover everything. But I will say that remote monitoring and algorithm have a very large role to play in heart failure patients. We can really, because in many small cities where the patients go back from after being treated for acute decompensated heart failure, they don't have the available specialist, heart failure specialists to take care of them. But if you have frequent virtual meetings with the patient every month or every 2 months, and monitor these simple clinical parameters, particularly the body weight, fasting body weight is very important, heart rate is very important, and by these blood pressures, these simple parameters, patients can be monitored and they can achieve very good results. I think I will stop here. I've stopped before time, so we can have some discussion. Thank you very much.
Thank you, sir.